Hello and welcome to the review for Chapter 18 from the Isham Textbook Edition 8. This review will be in two parts. So if you have the textbook, I'm starting on page 374. In the introduction, it states that healthcare consumers demand quality in the products and services they receive. We do. We don't often think about it as a patient. Hey, I hope that everything goes right. I hope that sterile processing is giving the doctors and nurses the high quality sterilized items which I need, or that all of the supplies that are brought to the case are sterile and everything's accounted for. Patients are worried about whether the surgery will go right, and it's on us to do everything we can to make the surgery go right. So, patients are not our direct customers, excuse me. Patients are we serve them indirectly by serving our internal customers. And our internal customers are the doctors and nurses that provide the immediate hands-on health care. Okay, with that in mind, we have to make sure that we provide the highest quality products and services that are possible. And we're going to do this by making sure that we can identify quality. Okay, so keep in mind that with emerging antibiotic-resistant bacteria and increasing complexity of surgical instrumentation, it's never been more challenging than it is now to provide the highest quality instruments, devices, functioning patient care equipment, supplies. So, but what is quality? Quality refers to the degree or the grade of excellence of a product or service. So, how do we know if we are providing quality for the patient, who is at the center of every quality concern? The patient is always at the center. Of course, we're concerned about making sure the doctors are happy, but they're concerned about making sure that the patient lives and that the patient doesn't get ill afterward from an infection. A little side note, I did have a surgery where the doctor told me afterward that even though he was assured that everything would be available for the case, as it turned out, everything was not available. So the surgery did not go as planned. So now I would see it a little bit differently than I did before that, because it caused me some issues with my nose. Okay, how do we identify quality? That is a really good question. How do you identify quality? If you ordered something new online and it gets to you and it doesn't work, you're going to assume it's poor quality. So this also happens in CS. If you order a piece of equipment or something as big as a washer or a sterilizer and it actually does not perform the way it was supposed to perform, you're going to assume it's low quality. If it does perform the way it's supposed to perform, you're probably not going to call all your friends and say, hey, you got to get this washer, it's the best. But you're just going to say, hey, it's working, that's good, then we're getting what we're paying for. How does the OR identify quality? The OR identifies quality whether or not we are providing instrument sets that are complete, that the instruments are all functioning, that they're there on time, that they're clean, thus sterile. The OR is probably going to let us know if they get something that's not right. I've been in situations where it seems like the OR is just giving up. They're like, why? They don't do anything down there to change anything. And down there, that's us, the people downstairs. Okay, I think about patient care and how it's being affected by the CS department providing such low quality products and services that the OR is just throwing their hands up. Okay, that's not good. There's things they can do, and they can send us down a pick list where the case didn't have the correct supplies on it or missing supplies, or a count sheet where the tech who assembled the tray made errors. Okay, this is it's almost nothing in regards to making sure that you have the highest quality standards. Something that's better would be doing sending up a survey that asks key questions like how are we doing, was everything right? Take those surveys back, go through the surveys, look for areas that can be improved upon, and go from there. I'm going to briefly go through this chapter because it is a big chapter and there is a lot of information in it. I'm hitting some key points. I'm on page 376 if you're following along. Now, empowerment. This is the act of granting authority to employees so that they make decisions into their areas of responsibility. Sorry, I slaughtered that sentence. Empowerment means that you are empowered to make decisions as far as how you produce quality. Not decisions for the entire department. You don't want to throw a monkey wrench into the system and say, I'm going to do this if it is going to have an impact on the entire department. Example, you may notice you're working in a place where they do not remove the filter retention plates before they put them through the cleaning process, but you know that they should. Well, if you just decide on your own as a lone wolf to do the right thing and it's not a group effort, you're throwing a monkey wrench into the system. So you're not empowered to disrupt a process. You are, however, empowered to talk about changes to a process in meetings, weekly meetings, daily meetings, try to get the supervisor on board. But you're going to be a supervisor or a manager, and then you're going to look at these things that we can improve on, and you are going to implement the changes. However, for your techs, if they decide that they want to move something small to a different location so that they can cut time in doing their work and it doesn't disrupt the process for everybody, this is good. This is what we're talking about, empowerment. On page 377, there's a chart. How do we know if we are providing quality? Well, we could wait for feedback, or we could ask for feedback in the form of surveys, but we should also be measuring it. I've been in a place where we had average of 200 trays down. Look at the chart on page 377. It says average trays backlogged at 7 a.m. Our goal is to have less than 15, and we actually had 42. So imagine having 200 trays down and trying to scramble to get instrument sets ready for cases even that are still yet to go today. You have to keep an eye on this kind of thing because not having instrument sets available and sterile when they're needed is poor quality service. So track quality. Track it. Track your quality. Principles of quality management. There's 4 bullet points here. Several principles of quality management form the foundation of quality processes. Patient focus. Always the patient is the center of everything, and assuring that patients' needs are the driving force in decision making, problem solving, and other activities. Process management. Place emphasis on managing the process rather upon managing the employees. So you've probably been in a situation where you felt like you were being picked on by your boss. A lot of people feel that way. And this is what happens when you're managing employees instead of managing a process. You might have been making mistakes, but maybe there was something wrong with the process. So we want to look at our processes and see what kind of changes we can make to make the process work smoothly and eliminate errors and not blame it on the humans necessarily that are on the front lines trying to provide the highest quality. Continuous quality improvement, believe that things can always be done better, and this is something that's always true in everything. There's always a way to improve something. So let's just say you're in a widget factory and you personally have been able to put out 75 widgets per shift, and you are empowered to increase your productivity. Your improving your personal process, but there are ways when you look at a process and figure out every step of the process, what's happening and what can be changed to improve the process. This is a managerial thing mostly, but within your scope of responsibilities, you can improve your own process or improve the way you perform the process. And then make fact-based decisions that are based on facts rather than assumptions. Always a good idea. On page 378, there's nothing I'm going to go over other than to talk about cross-functional teams. Sometimes operating rooms and and SPD departments butt heads, and it could be something that's really easily resolved. So you could form a cross-functional team to look at an operational problem. Some functions that are happening in a process that could be changed if we just all would get together and talk about what those things are. So, for an example, sterile processing may be picking all of the cases for the operating room. Now, when the operating room picks their own cases, they can look at a pick list and say, oh, well, Dr. Jones, he doesn't use this particular item. What he really wants is this, even though the item that is on the pick list is the one that the tech knows Dr. Jones doesn't want. This is something that can be brought up in a cross-functional team where maybe the end result will be somebody is assigned to go through the pick lists and literally make the correct changes. And this will ease at least some of the pressure between the OR and sterile processing. Okay. Quality control indicators. CS quality control indicators are often used to determine how well the department is meeting its objectives. Several quality indicators should be monitored periodically. Some examples of CS quality indicators are customer departments receive STAT or urgent medical supplies within 5 minutes of request. You know, STAT means right now. So only sterile supplies with current dates are available on supply carts, which means that somebody's going to have to go through and make sure that everything is current, sterile, not compromised in any way, has outdates. All right, a little side note. My itches. But no, seriously. A little side note. There's often just not enough hours in the day or enough staff to do everything that needs to be done. So this is to the managers of the future. Go and fight to make sure that you have enough people to perform all of the duties that need to be done in sterile processing. And when you have downtime and there are no sets coming through and you still have members of the staff that are sitting there looking at YouTube on their phones, don't let them do that. Have them go and do the things that need to be done. Like go through all of the supplies and the stock, make sure everything's good and still has evidence of being sterile still and not outdated. Okay. And that is something that you're going to want to do if you are concerned about quality. And you are. Analysis of quality concerns. So here's a couple terms you may not have heard of if you weren't paying attention in class. Failure mode and effects analysis and root cause analysis. These are widely used methods to analyze issues discovered within quality systems. Okay. A failure mode and effects analysis is a proactive approach to quality. It looks at a process or a system and looks for potential failures in that process or system. And so it's proactive, failure mode and effects analysis. It seeks to accomplish several things. First, it aims to define the topic that must be addressed. Example, replacing a hospital boiler. Then you assemble a group of multidisciplinary staff to identify possible hazards and causes. Example, poor steam quality, pipe ruptures, and service disruption. Finally, the team identifies actions and outcomes for each potential problem. For example, before replacing the boiler, it may be important to rent a temporary steam generator to use if problems arise. Imagine trying to run a sterile processing department without steam. So, that FMEA may be something that a manager would be involved in. Definitely would affect the department if there was a disruption in that service of steam. Okay, a root cause analysis. A root cause analysis looks backward at an occurrence. What happened and what caused it. So let's use a sentinel event for the what happened. Patient died. Patient died in the operating room. And that is a sentinel event, which is an unexpected occurrence which involves death, serious physical or psychological injury, or the risk thereof. So if a patient dies, the Joint Commission says that a facility must conduct root cause analysis on any sentinel event that is recurring. I don't have the exact number of times it must reoccur, but let's just say it only needs to happen once. If the patient dies and there's no obvious reason why the patient died, then they're going to want to look into it. So they're going to go through everything in the operating room, all the supplies that were brought in, everything that was used, everything everybody was doing, and they're going to see if they can look and determine what in that process went wrong. Okay. Well, how about this simple 5 bullet point root cause analysis? Starts on page 380. The surgeon, however the instrument was used. I'm sorry, these are members of the meeting. Members of the meeting. They should be the surgeon, and he's going to talk about how the instrument was being used. Okay, surgeons break instruments all the time. Misuse. The scrub tech and the circulating nurse, what happened? Was the instrument checked before giving it to the surgeon? The CS manager and the tech who assembled the tray, what are set policies and procedures for instrument assembly testing? Was the instrument properly checked? If you haven't figured it out yet, an instrument broke in the surgeon's hand while he was using it. The risk manager usually serves as a meeting facilitator and any other interested parties. The instrument repair tech, infection prevention personnel. Okay, so an instrument breaking while the surgeon's using it. It's not quite a sentinel event, but it's not a good thing. It's our responsibility to make sure that things are usable when they get to the OR. So remember the terms FMEA, RCA, sentinel event, quality assurance, total quality improvement, continuous quality improvement, work process, and total quality management, TQM. Okay, study the terms total quality management, total quality improvement, and continuous quality improvement. Understand what they are and what the difference is. The differences seem small when you really look at the definitions, but let's go over them. Total quality improvement involves measuring the current output of a process or procedure and then modifying it to increase the output, increase efficiency, and or increase effectiveness. So TQI recognizes that improvement can occur with an individual, a team, an organized unit such as the CS department or the organization itself. So what is unique about that? We're talking about measuring current output and modifying it to increase output. All right. Continuous quality improvement. Statistical method to improve work processes. I'm just going to stop right there. Statistical method. So, we're continuously collecting data, statistics, so that we can continue improving our work process. And then there's total quality management. What's different about that from the other two? It's an organization-wide quality approach based on participation of all members. So TQI and CQI could be just relegated to the sterile processing or one department within the hospital, whereas TQM is the entire organization. Moving on, please look at page 382 and the chart on the top. It's a bar graph, and it shows how they are tracking quality. They have less than 10 broken instruments that were sent up in trays. They have, looks like about 2 dirty instruments that were sent up in trays. This could possibly be over a month's span. It doesn't really say. It looks like this particular facility has a real problem with missing instruments from sets. This could be something that techs need to be educated on. It could be a change in the process that needs to be made where instruments would stop migrating from tray to tray, which is often what happens and why instruments go missing. And this could also be connected to the fact that there aren't enough techs to do the work, and in which case trays don't get put up when they should. The instruments that are missing from one set are actually in another set, and it's sitting over there on a shelf somewhere and nobody's assembling it. But track the errors so that you can really focus on ways to bring that number down. On page 383, we're talking about Six Sigma and Lean Six Sigma. Six Sigma. The objective of Six Sigma is to deliver high performance, reliability, and value to the end customer. It's a highly disciplined and complex process that focuses on delivering and developing near perfect products and services in an ongoing quality effort. Okay, this process strives to eliminate variations in a product. So, example, a tray can look the same way every time it's assembled. So, moving on. And will look the same as every product before it. Eliminating variations to prevent defects. It focuses on process improvement and variation reduction by use of Six Sigma projects. 2 of the processes most used in Six Sigma are DMADB and DMAIC. Okay, so first off, there is no such thing as perfection, but we would like to be able to deliver near perfection, or as high as we can get. So setting up trays to look identical each and every time can actually help the tech who's setting it up to realize that they're missing something. Let's say that the Deaver retractor usually sits right here and they don't see it. Obviously it's missing a Deaver retractor. Okay, the DMADB and DMAIC, let me give you a hint. Define, measure, analyze, design, and verify. DMADB is for designing new processes or developing new processes. And DMAIC is define, measure, analyze, improve, and control. So this is procedures to monitor and improve existing processes. And these both fall under the whole Six Sigma flag. Lean is not the same as Six Sigma. If you look at the chart on page 383, it shows that they're similar, but they do have slightly different purposes. Lean is to eliminate as much waste from production as possible. So, waste could be time. In a lean, if you're looking at a lean program, you could be rearranging furniture, rearranging the department so that there's not so much time spent going from area to area. And this is, lean is focused on reducing waste. Okay, quality at work. If you're looking at page 384, you see all those post-it notes stuck to a whiteboard, and you're probably thinking, what a waste. No, it's not a waste. It's less than 2 packs full of post-it notes, but it's ideas from the workers. They ask the workers, hey, put your ideas and your thoughts on how we can eliminate wastes in our processes. And it looks like some people put up a lot of ideas, probably good ideas. But I don't work in their department. Okay. The Joint Commission on page 385. The Joint Commission is an accreditation organization that ensures quality standards are set, monitored, and maintained by member healthcare facilities. So there are many health and safety program requirements for patients and staff using recommended practices and guidelines from agencies and associations, including OSHA, AAMI, and the Joint Commission. Routine and unannounced inspections by the Joint Commission are used to monitor standards, and each member facility is graded on its performance. Okay. Oh, the Joint Commission requires that any Sentinel event be reported and thoroughly investigated to correct the causes. Actually, that's a good point. And an earlier paragraph, it seemed to indicate that it was just recurring events. Okay. The Joint Commission. You may hear people getting all freaked out that TJC is in town. So my best advice on this is always treat every day like the Joint Commission is in town. Make sure that all of the stock gets rotated, that there's no compromised packaging, that everybody understands the right way to do things according to the instructions for use. Treat every day like it's Joint Commission Survey Day, and then you'll always be ready. CMS is the Centers for Medicaid and Medicare Services, and they're just like the Joint Commission. They can come in and do surveys unannounced or announced. So what is the risk of failing one of their surveys, either the Joint Commission or CMS? The risk is your hospital could lose the ability to get payment from the government for services rendered to Medicare and Medicaid patients. So without having the option to turn the Medicare and Medicaid patients away, they'd still have to provide the services, pay the staff, pay the doctors, spend money on the supplies. So obviously you don't want to lose your accreditation. Okay, we're going to pause this, and I'm going to begin part 2 of this right now.